All right, lymphoma. All right, so our last little section here. All right, so lymphoma, we have Hodgkin's and non-Hodgkin's lymphoma. So we'll differentiate these two. The worst one is which one?
Hey, Jeff Rosenthal, who's a writer at Party of Five.
That guy, really?
Yeah. Go ask him.
Excuse me. I'm sorry. Can I talk to you for a second?
Sure.
I was sounding a little crazy. Wait, did you work on Party of Five?
Yeah.
You remember the season when Charlie had Hodgkin's?
Right, yeah.
Yeah, okay. So, in the show, didn't he have good Hodgkin's?
Well, he had Hodgkin's that he survived. I mean, I don't know if it was good. He survived it, so that was good.
But isn't there a good Hodgkin's and a bad Hodgkin's?
No, there's Hodgkin's and non-Hodgkin's lymphoma, and Hodgkin's disease has a better survival rate.
Okay, so that's a better Hodgkin's.
I mean, that's a valid point, but
Okay, so
I wouldn't say it was good.
it's better.
Maybe it's better,
Okay,
but not good.
better. Okay, there's two kinds of Hodgkin's. One has a better survival rate than the other.
Right.
Okay, so it's good.
No, it's not good.
Well, it's better than the other.
Okay, better, but it's not good.
Well, compared to the other, it's good.
So good Hodgkin's is Hodgkin's lymphoma. Bad Hodgkin's is non-Hodgkin's, right? Non-Hodgkin's is the one that has it spreads a lot faster, it's more aggressive, and it will spread from lymph node to lymph node. And Hodgkin's, either way, they present with lymph nodes that are super swollen, right? There's been a lot of TikToks where they identify lymph nodes on the neck or lymph nodes on the shoulders, like, oh, you need to get that checked out. And they end up having like Hodgkin's. Okay, so here is our cervical lymphadenopathy. I have a huge lymph node there, right? This is a lymphoma. So lymph is your which cells? It's your B cells and T cells, right? B cells and T cells hang out in lymph nodes and spleen, right? So those can overproduce, which is happening here. Instead of in the bone marrow, like our leukemias, these are all occurring in a lymph node outside the bone marrow, right? So you have extreme amount of B cells and T cells being developed. And they, of course, can spread through the whole body, the worst one being non-Hodgkin's. And they can have mass effect. That's the idea behind the mass effect. They can push on localized structures, causing symptoms. So this separates us between Hodgkin's and non-Hodgkin's. That's the idea behind the blue bar there. So in the top half is our Hodgkin's. All right. Usually when either one spreads, it goes lymph node to lymph node to lymph node, and of course the more aggressive one being non-Hodgkin's, right? But Hodgkin's, that's 14% of our lymphomas, and it occurs in usually higher affluent culture, higher affluent societies, higher socioeconomic status. It has a bimodal presentation where you have it happens in kids or adolescents and happens in age greater than 55. It's associated with Epstein-Barr virus. It's associated with HIV, immunocompromised patients can develop Hodgkin's. Usually a recent viral infection will generate this response. And with this swollen lymph nodes, if they were to biopsy it, it looks like this. It looks like an owl. It looks like owl eyes. They call it Reed-Sternberg cells. That's just a unique finding for Hodgkin's. And then since these B cells and T cells are growing and growing and growing, just like leukemias, you're going to get night sweats, you're going to get fever, you're going to get malaise, and of course your lymph node is going to get swollen. But all these symptoms of flu-like symptoms plus low-grade fever and night sweats, they're called B symptoms. Well, aren't those leukemia symptoms B symptoms? No. Those are B symptoms, belong to lymphomas. That's what hematologists say, but they are B symptoms. They're just symptoms of overproduction of these white blood cells. Okay, you can get pruritus. What's pruritus? Itchiness. Do those B cells? The B cells produce basophils, and basophils make you itchy. Lymphadenopathy. That's a swollen lymph node. That lymph node is going to be painless, right? For both of them, painless lymphadenopathy. There can be some things that exacerbate it, such as alcohol for non-Hodgkin's, but otherwise they are painless lymphadenopathies, and they're usually rubbery in appearance and in feel, usually greater than a centimeter in size, right? And they both can have mass effect on different organs, right? Nearby organs. They can, if it's in the mediastinal area, it can compress the heart. If it's by the lungs, it can compress the bronchi. If it's in the retroperitoneal, it can start compressing the GI tract and such. It could compress the urinary tract, all right? So it could compress the esophagus, causing swallowing difficulties. So that's really a complication of Hodgkin's, is it's compressing nearby structures, okay? And Hodgkin's rarely leaves and metastasizes compared to non-Hodgkin's, which likes to metastasize. It metastasizes to many lymph nodes and eventually makes its way all the way down and through the body, okay? So what else? So non-Hodgkin's is a link to, again, benzene and pesticides. So you get a farmer non-Hodgkin's. All right, sounds like I buy bacon from him. Anyways, we got complications of this mass effect would be the what's called SVC syndrome, and we have a slide that's on the next slide. But the superior vena cava gets compressed. All right, non-Hodgkin's is aggressive, and it starts pushing and pushing and pushing, and it starts compressing the superior vena cava, causing symptoms, which we'll describe in the next slide. You get tumor lysis syndrome with non-Hodgkin's because it's you're producing all of these cells, all these B cells and T cells, and they're actually kind of making their way in the bloodstream a little bit, and they're going to start causing the breakdown of these cells, leading to our signs of tumor lysis syndrome. What were those signs again? What are those diagnostic tests we can look at? It's pluck, hyperpluck, except for the C, because it's silent, I guess. Right? So the C is low with the first P. So phosphorus is high, calcium's low. What's the L stand for? LDH. What's the K stand for? Potassium's elevated, right? And U stands for uric acid. Okay. Sometimes this again, it migrates and metastasizes, and it can go into the bone marrow. When it goes in the bone marrow, it's going to start causing the bone marrow to shut down. You're going to have anemia, and you're going to have our low platelets, right? The other feature of non-Hodgkin's, because it's more aggressive, it causes your blood cells just spontaneously start bursting. All right, it's called hemolytic anemia. It causes a widespread hemolytic anemia. So not only are you breaking down your white blood cells, but now you're starting to break down your red blood cells. They can start getting yellow. All right, so symptoms and how do you fix it? So lymphomas are, the biggest symptoms that were on the previous slide, but how are complications? We have mass effect on local structures, like we mentioned. How do we fix that? We can debulk it. We can take out the lymph node, or we can give radiation to shrink it down, and then we can take it out. SVC syndrome, so you see this girl over here had a superior vena cava that was compressed, right? And when it's compressed right there, you don't have blood flow, so face can get swollen, the nerves can get compressed, and they can get a facial droop. They start to compress and impede flow into the heart. You get hypotension, and also and chest pain because of that. So it's a oncological emergency. It's an emergency due to a cancer process, right? Myelodysplasia, that's just where our bone marrow is not working because it has now invaded into the bone marrow, right? Febrile neutropenia being a big concern, right? And then also the feature of hemolytic anemia being a problem with non-Hodgkin's. Tumor lysis syndrome, non-Hodgkin's, and all this extra B cells and T cells makes our blood very, very viscous. And when it's viscous, it starts causing VTEs. All right, so fluids and heparin can help with that. So diagnostic tests for someone with Hodgkin's or the CBC will really be normal unless the B cells, T cells have made their way out and are now in the bloodstream, and also it starts invading the bone marrow. Then you would start having those changes with anemia and low platelets, right? They can do a lymph node biopsy. They see Reen-Sternberg cells in which one? In Hodgkin's lymphoma. They might have to do an LP if there's CNS spread, but usually surgical resection is the treatment. They do multiple chemo sessions by 8 cycles, not as much as like leukemia, but 8 sessions is 8 sessions. That's to debulk it, right? And they usually do autologous stem cell transplants. Same situation where you take all the blood, you treat it, and then it's given back once you've been myelobliterated. They've wiped your bone marrow clean, then they can restart it with your own bone marrow. This is an example of a fine needle biopsy where they take a sample of the bone marrow, a sample of the lymph node to assess if it's Hodgkin's or non-Hodgkin's. All right, our last section is multiple myeloma. So multiple myeloma is where we have way too many B cell activity. Way too much B cell activity. What do the B cells do? Technically the B cell, the plasma cell. So we have too much plasma cell activity. Plasma cell makes antibodies, right? So way too many antibodies. All right, so we have plasma B cells producing way too many antibodies. It's a plasma cell schizophrenia. It's like, well, shoot, you see an infection? No. So you see an infection, I'm producing I'm producing some antibodies for you, no problem. And it's like, no, there's no infection there. No, I'm producing this right now. Here we go. I got 10,000 of them for you, right? So it produces all these plasma cells. It's so distracted, it won't fight off your regular infections. It's like, hey, I got a flu. Can you give me some plasma, some antibodies for that? No. So you got this guy right here. We got to fight off that infection. So it's a schizophrenia of the B cells, or the plasma cells. Okay. So because of that, we have it's called a monoclonal gammopathy. So we have too many IgGs, basically, right? Too many IgG antibodies. Right. So what else happens? So we get excess antibodies, and those antibodies you can measure that. We can do a blood test to measure how many antibodies there are of each type. You have alpha ones, beta ones. It's the gamma ones that increase in amount, just per statistics. Okay. Also, not only do they produce antibodies, they produce a BJ protein. Right, and the BJ protein is really sticky, and it sticks to the RBCs, and the RBCs start clogging the kidneys as well. It's called a Bence-Jones BJ protein, and that leads to kidney failure. And then the antibodies themselves can actually clog the kidney. So not only does the BJ protein do it, but also the antibodies as well. Okay, and then also this huge inflammatory response triggers osteoclasts. We'll talk a lot about osteoclasts next week, but osteoclasts are involved with bone breakdown. They cleave bone. Osteoclasts cleave bone. Osteoblasts build bone. So these guys are going to cleave the bone, and you start getting lytic lesions. This is like a unique finding for this cancer. All right, so they start chewing away at the bone. Okay, so you have overproduction of antibodies is the take-home point. All right, so risk factors, again, herbicides. We've got a farmer here as well, right? And they have way too many gamma antibodies being produced. It's against an infection that does not exist. All right, so you can see down here on the right are lytic lesions. They do a skull X-ray. You can see they've just like been chewed away. Usually, when someone gets like a routine X-ray, they can start seeing pieces of the ribs being chewed away, and that's like always multiple myeloma. They have to now be treated for that now. Okay, so the symptoms are CRAB is the mnemonic. All right, C is the calcium, since they're chewing away at the bone. The calcium from the bone makes its way into the bloodstream. So the calcium is super high. Renal failure is the R, so because the BJ protein's clogging the kidneys, the antibodies are clogging the kidneys, and the BJ protein is actually toxic to the kidneys themselves. And so the renal failure is present. A for anemia. All right, so we have the bone marrow can get infiltrated by these plasma cells, leading to the RBC production to shut down. And then bone pain, as it starts chewing away at the bones, it's painful as well. They have these lytic lesions, and then you can have spinal cord compression, which we'll talk about more next week. Okay, so different tests we can do. We can test for the Bence-Jones protein. It makes we mentioned it makes the RBC sticky, so it makes they form this like rouleau formation, little stacked RBCs. And then what else? So we can measure, like I mentioned on the previous slide, we can measure to see if that little gammopathy exists or not. Okay, they can do a bone marrow biopsy, and they can take out a piece of the cells to see if they have a whole bunch of plasma cells that have infiltrated it. All right, if it's more than 10%, you pretty much have multiple myeloma. All right, the treatment is bisphosphonates, which we'll talk about next week. They stop osteoclast activity, right? And then dexamethasone, steroids stop B cell activity, right? Steroids will stop that immune response. Chemo is to shut down the plasma cells. We use regular chemo, but then we're going to make a return of thalidomide. And thalidomide used to be sold to women in the 50s to make sure they can sleep better at night. And then they said, yeah, just take it, you're fine. And then they had kids with no arms, right? So that was a big problem. So then they finally, Australia finally got justice, and they got like $90 million to the people that had no arms, all right? So that was a oopsie. So what else? So thalidomide, though, if you're not pregnant, is great for multiple myeloma. It has made it resurface. That's kind of just is the only reason nowadays. We'll talk about bortezomib and alkylating agents coming up soon. All right, stem cell transplants, again, we're going to restart it, and we can usually maintain them on chemotherapy. If that doesn't work, then we can do a stem cell transplant. With all these antibodies floating around, it can clog your vessels, so they're going to be on like heparin and Lovenox as well. Okay, so that is what hematology, and then we'll come back for oncology.